Well, our keynote speaker today is Dr. Barbara McAneny, and she is the president-elect of the American Medical Association. So just like our legislators who are kind of bleary-eyed, spending late nights up at the special session, Barbara is actually joining us from a trip back from the American Medical Association. So she was just talking about the night flight back to Montana, and we all can empathize with that because we've all taken those kind of crazy flights to get back in town and get up and going the next day to be back in gear to share the word with other folks. But we are extraordinarily delighted, and it's our pleasure to have her here in Montana. And we're just pleased to have someone of her caliber here to talk about her insights on the transformation of healthcare. You know, she is a board-certified medical oncologist, hematologist from Albuquerque, New Mexico, and she was elected president-elect of the American Medical Association in June of 2017 after serving on the AMA Board of Trustees since 2010. She is an impressive leader, an out-of-the-box thinker, and has demonstrated through her actions the importance of collaborations to support success, as with the move to quality payment programs. And she knows firsthand how data can be used to promote best practices. In 2012, she received a $19.8 million award from the Centers for Medicare and Medicaid Innovation to test how oncology private practices could provide cancer patients better care at a lower cost. She's now sharing what she's learned with other practices. Join me in welcoming the doctor.
Thank you very much. It's a great honor to be here and to be asked to address you on behalf of the American Medical Association and to talk about physician leadership and the importance of partnership in this new age of medicine. This is actually my second trip to Montana in 6 weeks. I was just in Whitefish with your oncologist. And I'd consider staying. It's beautiful, but I learned a long time ago I'm not as tough as you guys are. I trained in Minnesota and Iowa, and now I'm in New Mexico for a little better weather, a little warmer. But I am happy to be back to this beautiful part of the country. I've been an oncologist in New Mexico for 33 years, and I cannot recall a time when there was this much scrutiny on the practice of medicine, this many unnecessary burdens placed on the shoulders of physicians, and any more uncertainty about where our profession is going. It's my honor to have been elected by my peers and colleagues as the next president of the AMA, because I believe the AMA is the only organization with the ability and the will to empower physicians and patients and to advance the policies on the issues that really matter. For more than 170 years, there we go. The AMA has been the voice of American medicine. Our House of Delegates represents 186 state and specialty societies. We interact with physicians at all stages of the physician life cycle, from student to resident to young physician to retired. We work in all practice settings, from the individual solo physician to the multi-specialty group to the academic medical center. And this has allowed us to contribute to or lead many of the major innovations that have gone on in healthcare in the last century and a half. From the Flexner Report in 1906, which established medicine as an academic discipline, to developing the Code of Medical Ethics, which is the underpinning of everything we do, to working for tobacco use cessation, seat belts, vaccinations, and of course, most recently, access to health insurance for all Americans. We're very proud of this work, but there's much more to do. This only wants to go one direction. There we go. We spend $3 trillion a year in American healthcare. It's the most expensive system on the planet. So what do we get for all this money? We rank 19th among organized, industrialized nations in health outcomes, 19th. We rank 42nd in life expectancy. Our high cost of healthcare is leaving many Americans out of the system altogether, which is why 2/3 of all bankruptcies in the United States are triggered by a medical event, and 2/3 of those people have insurance. This is unsustainable, it is unfair, and we have to fix it. The bureaucracy in our system means that so many in healthcare today, so many of the people working are wishing that they were doing something else. Our own studies have shown that more than half of physicians are experiencing some symptoms of burnout. I felt it at times, and those of you who are in medicine have probably felt it as well. The modern healthcare system is overloaded with regulation and middlemen that get between physicians and patients. And the rigid requirements that make us feel like data entry clerks, like cogs in a profit-making machine, rather than the healers that I went to medical school to be. We are working in a system that seems designed to maximize the profits and the power of large hospital conglomerates and large health insurance companies and pharma at the expense of patients and physicians. It's very profitable, but should that be the goal of a healthcare system? I don't think so. The good news is we can do something about these frustrations. And through creative partnerships across healthcare and beyond, we can shape the future of medicine so that it works better for physicians and produces better outcomes for patients and doesn't spend that much money bankrupting our patients and leaving nothing for parks and roads and other necessary infrastructure unless we curb this. And the AMA recognizes that collaboration is the key to advancing these healthcare initiatives in this new age. We have steadily worked to build partnerships with other leading health institutions, with the business community, with patient advocacy groups, with specialty societies, with universities, and many others. And these diverse partnerships are helping as the AMA is taking on some of the toughest challenges in healthcare today as physicians navigate this incredibly complicated world of medicine. We're doing this by elevating physician voice on national and state issues that matter, by collaborating with tech innovators and entrepreneurs in the new digital breakthroughs that will transform clinical medicine, by harnessing the power of healthcare data in new ways to produce improved patient outcomes and to work on interoperability across systems, and by trying to reinvent medical education so that the doctors of tomorrow are better trained and better equipped to work in increasingly diverse, technology-driven, team-based environments. This is the future of medicine, and these are some of the causes that I look forward to working on when I get to be president next year. But let me show you how we're doing some of that. Except the slides went away. There they are. There we go. Because of the change, and our system is very high-tech and highly regulated, and is increasingly focused, as a previous speaker said, on chronic disease management, and increasingly demanding on physician time, physicians are becoming overwhelmed by external demands, these burdensome regulations, entering data that doesn't seem to matter to us. And the study that we did with the Mayo Clinic showed that 54% of physicians have some degree of burnout, about 20% want to cut down their amount of clinical work, about 10% are considering leaving the profession altogether. And this is at a time when baby boomers are aging, and we're going to need more and more physicians to take care of the chronic illnesses that plague our nation. But our days are filled with too much paperwork. A Dartmouth study we did showed that for every hour we get to spend interacting face-to-face with patients, we're spending almost 2 hours interacting with a computer. A recent study with the University of Wisconsin showed that primary care physicians, during the course of their day and into their evenings, are spending 6 hours every day entering data. Is this the best way to use the most highly trained member of the healthcare team? I don't think so. It's tremendous waste in our system. It isn't improving outcomes for our patients. And so we need physician leadership with allies inside and out of medicine so that we can envision a better future for healthcare and provide the resources that are necessary for the practice environment. Physicians do actually love gadgets. We like new gadgets. We all have iPhones or Samsung devices. Everybody is trying to innovate, but we like devices that work. But we are saddled with electronic health records that are not working very well. When we look at the electronic health record, the information that we collect, the data we put in is enormous, but the ability to find any evidence from it, any useful information is decreasing. And so we've established some priorities to try to guide EMR development. We think that the regulators who created meaningful use, what we tend to call meaningless use, missed the boat when they did not insist that the EMRs be interoperable, have a common terminology so that an appendectomy in one EMR is an appendectomy in the next one, and be able to really use the data that we collect so that we can not only take care of the patient in front of us, but we can look at the processes that are necessary for us to be able to take care of the collective group of patients that our practices serve. We also need to have greater cost transparency. In my practice, I've purchased my third EMR. If I ever do a fourth one, I'll have to go into the witness protection program because my partners will take out a contract on me, I suspect. It's painful, and every time you need to have an interface created with a lab or an imaging center, that's another $20,000. We heard about the $400,000 that the hospital's paying. That's not uncommon for any of us. We also see data blocking. They all deny that they do it, but they want to keep the records within their system so that you can't switch from one system to a better one. Once they have your records and they've cashed the check, they've got you. And we now have set up a process for physicians to give this information to the federal government so that we can take action when these occur. But a whole lot more needs to happen. We cannot have physicians spending half their days in front of a computer screen and not have enough for patients. Another example of what we're working on is prior authorization. How many know what that is? Good. It's playing Mother May I. Every time you want to do something for a patient, write a prescription, order a test, order imaging, refer to a specialist. Did you know that the average primary care physician does 37 prior authorizations a week? Think about the time that takes. In my practice, I pay 3 people full-time salaries just to get prior authorization, and I'm an oncologist. They're going to turn down my giving chemotherapy to cancer patients? They do about 10% of the time. And then we have to get on the phone and talk to the insurance company and get that reversed. I'll tell you a story. We had a recent incident of one of my patients who had her breast cancer was in the spinal fluid around her brain. In order to get chemotherapy there, you have to put in this device called an Ommaya reservoir, which has been around for about 30 years. The process was denied as experimental. This was 3 weeks ago. The neurosurgeon couldn't get the prior authorization. He got the peer-to-peer review, doctor to doctor, couldn't convince him it wasn't experimental. And then he said, you try. So I tried, and I couldn't get past the secretarial level of the prior authorization process. So after about half an hour of my blood pressure going through the roof and being really angry, which isn't good for your health, I finally stopped and sent an email to some of the physicians I know who are higher up in that insurance company. And I had to threaten that if they denied this, that I would encourage the husband of the patient to sue and that I would be the expert witness. So in about half an hour, I had a couple of emails and phone calls from some of the execs at the insurance company, and they authorized the process for my patient. But this is wrong. This shouldn't happen. And now I'm 45 minutes late, and my patients the rest of that afternoon were angry with me because I was so late. And that is why doctors get burned out. And this didn't add to the quality of care for the patient. This is just an expense, both from the insurance side and the practice side, that we could eliminate and improve the quality of care and decrease prices. So we've created a prior authorization coalition at the AMA, working with 16 other leading healthcare organizations, trying to find partnerships to broaden our reach, to urge an industry-wide reassessment of this entire process so that we can fix this and make it easier for doctors and for patients and actually for insurance companies. And it's starting to pay off. We have 2 Blue Cross companies in New York who've eliminated prior authorization processes on about 200 procedures. In Washington State, Molina eliminated prior authorization on 2,000. And we're talking to United Health Group about a program that will really get rid of the prior authorizations in their Medicare Advantage patients programs. And this is important work. It has direct effect on clinical practice, but it's a good example of something that wouldn't work without a leading organization stepping up and creating a coalition of people to work with us. And nowhere are the coalitions more important than in fighting increased consolidation. We just had a very important advocacy win earlier this year by leading a national coalition to block the proposed mergers of Aetna Humana and Anthem Cigna to go from 5 big insurance companies down to 3. We did this to protect patients from the consolidation because there's good data that as hospitals and health plans consolidate, quality stays the same, prices go up, and patient choice goes down. Imagine how well, if you needed a procedure that was denied, your physician from here in Montana would do trying to call some East Coast insurance company headquarters to get that prior authorization overturned. We did this to protect physicians from that overreach because we believe that physicians are the ones who can work best with patients to determine the appropriate course of therapy. We needed partners for this. We had a coalition of 17 medical associations, health economists, policy experts, attorneys general, and patient advocacy organizations. We lobbied it with the Department of Justice, testified in front of Congress, lobbied state officials, and we built the case, and we were successful. Federal judges cited AMA arguments in their decision to block the mergers, and all 4 parties have since abandoned these efforts, which is a huge win for consumers and a huge win for healthcare costs. I would point out that saving $500 million annually for the physician fees was a win because it would not have gone to lower premiums. It would have gone to higher insurance profits. And if they decrease the amount that they're paying physicians, more physicians end up abandoning their practices and going into either early retirement or selling the practice to a hospital. And I will let you know, you probably discussed this earlier today, but if I were to sell my practice today to a hospital, the patient that I see tomorrow, even though it was the same place, same doctor, same patient as before, would cost Medicare and Medicaid about 50% more, and would cost a commercial payer about 3 times as much. So cutting that fees would have cost us a lot in the long run. And of course, this last year, most of our efforts have been dominated by the national debate in Washington over repeal and replace of the Affordable Care Act. We work on the state level as well. We've done a lot of various state programs with multiple states looking at issues that they face. And we have a advocacy resource center that is available with model legislation to help craft bills that will promote better healthcare quality. We were and we continue to be, one of the most outspoken critics of the various proposals in Congress that would have stripped healthcare coverage from millions of Americans, because we know, and research tells us, that expanding access to health insurance increases the use of doctor visits, which has been shown to be the best defense against the rising tide of chronic disease, and to find and treat healthcare conditions before they require hospitalization, before they become life-threatening or disabling. We shared 9 principles with Congress that we feel must guide the legislative efforts to reform health system. Key among those principles is that those who currently are covered by health insurance must maintain their coverage, and we need to continue to expand the number of Americans with affordable, meaningful coverage. We all know that people who have health insurance live longer and live better than people who do not. But we didn't stop there. Though my slides did. There we go. There we go. So as we look at our priorities, each bill that comes out, we evaluate against whether it accomplishes those goals. I don't care whether it comes from either side of the aisle. We will work with both sides of the aisle to find things that increase the number of Americans who have health insurance. We never want to go back to the days that I saw firsthand where patients who we cured of a cancer could never get health insurance again because they had a pre-existing condition, or people who would hit their lifetime cap on coverage. As we led our own advocacy efforts, it worked this time, we call it Patients Before Politics. And this was a grassroots digital campaign that let physicians across the country and patients know how to contact their representatives in Congress. This microsite, patientsbeforepolitics.org, generated 33,000 phone calls, 380,000 emails, and over 6 million digital social media contacts with politicians about not taking away people's health insurance. This Patients Before Politics is not just a slogan for us. It's a value that we will continue to hold and to work for. We do know that the status quo is not working. The Affordable Care Act has flaws, and we need to address them. It will take a bipartisan effort that keeps the framework of the ACA in place, and we've proven that is going to happen, and need to improve the affordability of coverage, increase the access, and stabilize the individual market. And as the debate goes on, we will continue to advocate for those principles and priorities and work with all members of Congress to create sustainable solutions. Often, when we think about what's next in medicine, we start thinking about how technology might play a role. And there's certainly more to digital medicine than just correcting the flaws of electronic health records. And that's why we've created what we call our innovation ecosystem, which spans our work in health IT, precision medicine, our strategic and our advocacy priorities, and even helps guide our research. We are building creative partnerships across the healthcare space with tech engine entrepreneurs to improve the practice environment, but also to improve patient care and outcomes. We all know there are a lot of digital products out there. Many of them are marketed directly to patients, to consumers, and some of them make some pretty outrageous claims about what they're going to do to improve your health. The same is true for the technologies that are marketed directly to physicians. We don't know how many of them are safe or effective. And so it's our belief at the AMA The physicians have to have a seat at this table so that as we design these new technologies, it's done with physician input so that they actually work well in clinical settings. A couple of quick examples are Matter, which is an interaction studio where entrepreneurs and physicians are working together in Chicago to create common healthcare solutions to common frustrations. More than 200 healthcare startups are working with that. We're the founding partner of Health 2047 in Silicon Valley in San Francisco. This is an independent studio that combines the experience of physicians with engineers, coders, behavioral economists, psychologists, and many others to design new healthcare technologies to try to make everyone's life a little better and everyone's health a little better. The Physician Innovated Network is like digital matchmaking that hooks entrepreneurs and physicians together to combine efforts. And Exertia is a nonprofit or enterprise to promote industry guidelines for safety and efficacy in mobile applications. And most recently, our Integrated Health Model Initiative, working with IBM Watson, Intermountain Healthcare, and Cerner, is trying to create a new model for the mass of data that we all create so that we can extract that needle of information out of that data and use it for better outcomes. You mentioned earlier the quantity of chronic disease that affects our population. The AMA has been building partnerships to help physicians confront this generational rise in chronic disease, some of the leading causes of death and disability in our country. Half of all the visits to primary care are for chronic disease management, and almost 90% of healthcare spending is for people who are battling at least one and sometimes more chronic diseases, according to the CDC. So we committed ourselves to addressing some of the leading causes of death and disability, but the AMA cannot do that alone. Our work is to prevent type 2 diabetes, to find pre-diabetics and prevent them progressing on to diabetes, to work with hypertension, heart disease, and stroke, to build clinical and community linkages that will enhance the delivery of care and allow us to partner with patients for better health. We're working with the CDC, the American Diabetic Association, and the Ad Council to expand awareness of pre-diabetes by asking Americans to visit doihaveprediabetes.org and take a simple test and determine your risk. Public and private coverage of the National Diabetic Prevention Program continues to grow. Anthem Blue Cross just went from 2 states where they approved it to looking at it being nationwide. And in a victory for America's seniors, the Department of Health and Human Services authorized expansion of this coverage to Medicare beneficiaries. This is a multi-state partnership with many of the current states and is also working with many other organizations because pre-diabetes is not something that a physician is going to fix in a 15-minute visit 4 or 5 times a year. It is a lifestyle change which will require partnerships that are far beyond physician reach. So we have to develop those partnerships and give patients the tools that they can use to change their own lifestyle and prevent pre-diabetics from turning to diabetes. In addition, we're working with partnerships to help treat hypertension and heart disease. We launched, working with the American Heart Association, Target BP, which is a national effort to reduce the number of Americans who have heart attacks and strokes by urging physician practices, health systems, and patients to prioritize control of blood pressure. This website now has a task force of nearly 600 health entities, and partnerships are helping it go forward. If you can prevent blood pressure from being out of control, you can prevent a significant amount of the disability that faces our country and spends our healthcare dollars. We also are not ignoring, and we've actually been very active in working at the current national tragedy of opioid misuse and addiction. This is an epidemic killing 91 people a day. And we've been working for years. We have an opioid task force consisting of 24 state and specialty societies, with the goals as listed on those slides. The physician drug monitoring programs we have endorsed and are using across the country, we're making some headway on that. We've tripled the registration of physicians through those PDMPs over the last couple of years. That allows physicians to know whether or not a patient is also receiving paid medication from another physician at another pharmacy, etc. Nearly all 50 states have improved naloxone access laws. Naloxone is a drug that can reverse an overdose and can save lives. And we've decreased opioid prescribing by 17% between 2012 and 2016 through extensive physician education processes. There's been steady growth as well in the number of physicians who are now able to prescribe office-based medication-assisted treatment to treat these substance use disorders. But there remains a lot more to do. It's good that we're now recognizing this as a public health emergency, because it will take a public health approach by federal and state governments, by insurers, by physicians, and others. We have been urging every physician to be a leader in reversing this national epidemic. We launched a microsite that outlines our priorities, highlights the data, and provides nearly 300 state and specialty-specific educational resources that are meaningful and relevant to clinical practice. It's www.endopioidepidemic.org. So moving forward, we will continue to advocate for the removal of the barriers to treatment for substance abuse disorders. We need to advocate for access to other modalities to take care of pain, including non-opioid and non-pharmacologic, like physical therapy. We will continue to provide education and training throughout a physician's career on this issue. These are times of incredible uncertainty, with challenges and opportunities in equal measure in healthcare. Hopefully, I've shown a few of the ways that the AMA is focused on building partnerships with diverse groups who are willing to take on these challenges with us, because we are stronger when we all pull together in the same direction. This is a critical time for physicians and for all of us who have a stake in the future of our nation's healthcare system, which of course is everyone. Sooner or later, we are all patients, to get engaged and stay engaged in these efforts. We need more physician leaders. We need more leaders and allies in business, in patient advocacy, in medicine, in government, to rise up and work collectively for the betterment of our nation's health care. We cannot do this work without your voice and your support and your involvement. This is our opportunity to leave a lasting legacy on medicine that we can all be proud of and that will make a difference now and for generations to come. Thank you. Do we have time for questions? Or?
So we do have a couple of minutes. Does anyone have any questions?
We solved all the problems.
Solved them. All right. Well, again, thank you very much. Gift for you.
Oh, well, thank you. Appreciate it. And thank you for inviting me to your beautiful state. I appreciate it.
All right. Well, we're going to move ahead and ask the next panels to come forward, and while they do that, I just want to again thank the good doctor for coming to our state and talking about the importance of partnerships in our state. She talked about a couple of things, and I would be remiss in not mentioning some of the things that we're doing right here in our state that touch upon what she's doing, and one of those is administrative burden relief. When we talk about physicians and our administrative care and our healthcare providers out there, that ranks at the top of the list in regards to what needs to happen so that they can return joy back into the practice of medicine. We too are prior authorization fatigued in this state, and so we've launched our own state group, and just like Montanans do, we roll up our sleeves and folks come with us on that journey to have those conversations, and that includes Blue Cross Blue Shield, Pacific Source, Medicaid, and workers' compensation, and we know that group's going to get larger, and we're extraordinarily pleased to be able to have those conversations with those insurers along with our providers. We also in Montana are doing great work in regards to finding reductions in regards to the prescriptions for opiates. We're beating the national average in Montana in regards to reducing the number of prescriptions written in that regards, and we've got great work, and you'll hear more about that this afternoon on what else is happening in regards to that public health crisis. But in the meantime, there is a website out there called knowyourdosemt.org, a site designed for our providers, providing them education and a toolkit. And also, we'll soon have patient information, so they too can be part and engaged in that conversation. So with that, we'll have the panel. I kept talking and they kept walking, stopped walking. So come on up, Dr. Griffin, Sarah, and excited about the panel coming up. As you're going to hear from them in regards to other innovations that are actually happening in areas that have already been touched upon by our keynote speaker and others. So building on that as well. All right. And with us today, we're going to have you look at the program in regards to who our speakers are on the panel. We've got Dr. Griffin, who is with Blue Cross Blue Shield. Dr. Griffin also happens to be the president-elect of the Montana Medical Association, has been working on an initiative with the Health Information Exchange, and also is one of the thought leaders when it comes to moving in a different direction on how providers are paid based on value and quality. We also have Sarah Medley with the Mountain Pacific Quality Health Foundation. When it comes to work around preventing chronic disease, this is the foundation to look at. They do lots of wonderful work, but particularly you'll find of interest the good work they're doing in our communities to help do through learning connections, education on things like diabetes. And then we are pleased to have Director Hogan, who probably also was up till about 2 in the morning and scrambled over here as well, to talk about the good things that are happening in our Department of Public Health and Human Services. Many times they just don't get the credit that they deserve in regards to how innovative our own state employees are in moving the ball a different direction or in a ball to create better health in Montana. And with that, we have a moderator, Connie, our own expert as well. Now an insurance agent, but Connie, I think we first met when she was in the budget office. So many years ago, she actually was crunching all these numbers and providing wise guidance in regards to budgetary dollars. Since then, she's actually helped in healthcare plans and became quite the expert in regards to healthcare expenditures. And we're pleased to have her be the moderator. Connie.
Well, good afternoon, everyone. I'm really pleased to see all of the folks that are here. I know during a legislative session, a special session, it's quite an effort to make all of these things work, but this is an important conversation in Montana. So with the panel, I think each of the panelists today has some remarks and some thoughts to visit a little bit today about our healthcare innovation and driving down the costs. So we were very privileged to have Dr. McAneny talk about some of the things that the AMA is doing. And those, I think, for anyone that's worked in healthcare, If you have worked in different aspects of it, you see a different perspective on it, and that's an important thing. So I think our panelists all bring that aspect to it. So with that, what I'd kind of like to do is have each one of them start with some of their thoughts and some of their remarks and presentations, and then we'll take some questions, and hopefully we can kind of have a dialogue with the audience and each of these expert panelists. So Dr. Griffin, I'll start off with you.
Thank you. It's a great pleasure to be speaking with you all here today. And I did have comments prepared. After hearing the sessions, I just feel like I need to go off the cuff a little bit. So hopefully we'll keep things under control. But sometimes my enthusiasm, there are unintended consequences of my enthusiasm, especially for this topic. But I heard Representative Lynn say that in healthcare we're at a tipping point. And I thought that that was just such a poignant comment. It's so true. We have to transform this healthcare system. Otherwise, my friends, the Medicare Trust Fund, we can anticipate, at least a few weeks ago, I was giving a talk down in Las Vegas, and Captain Greg Dill, who is administrator of CMS Region 9, said that Medicare is slated to go broke in 2028 or 2029. And we're hearing about deficits in our state. We are seeing reimbursement being impacted in lots of ways. We're seeing challenges across the board. And we know that we have to change. And so really, what are the fundamental components that we're really aiming for? If you had to pick that one horizon point or that one outcome that was going to make a difference, what do you think that would be? I'm curious. As I think about it, you know, we've heard a lot today about management of chronic disease. We've heard a lot about prevention of illness. We've heard a lot about the administrative burden and the regulations associated with delivering care. We've heard a lot about the effectiveness of delivery care systems. We've heard a lot about the cost of doing business. And so it's a very complex scenario. And the one thing that we all need in order to transform this healthcare system is accurate, comprehensive information across the continuum of care. In order to be successful transforming healthcare, we actually need systems that make differences in people's lives. A system that can impact change for somebody who may not have a job or needs more education or has a severe chronic disease. There are a number of ways that we can impact people's lives so that they're actually healthier. That's where the rubber hits the road. And so if that's the horizon point that we're aiming for, and we've got to have systems that are most efficient and effective at helping people to change their lives and transforming our communities, our economies. We're thinking about behavioral health. So information to help us understand where things are right now, the current state, to help us understand what opportunities exist to transform our system and make a difference. And then the ability to gauge our progress as we're making changes and trying to transform. You know, Dr. Gibb stopped me earlier this morning. Dr. Gibb is the new CEO of Billings Clinic. And he told me today about some great news and great work that Billings Clinic is doing to create savings across their healthcare system. And some results that he can't talk about formally right now, but will soon. And I know that other hospital systems and providers in this state are focusing on this work. I think it's an important piece of this puzzle that needs to be concentrated on for a minute. Just the level of effort that's already going into this work. And that we need to support and, partner in helping advance that and expand that kind of good work. And so the transparency discussion then becomes very key. And of course, with transparency, we need information. There is no transparency without the data. And when data is fragmented, like it is, you can't get a picture of the full view of a comprehensive cycle of care for someone, or you can't get a grasp for how the utilization of healthcare services, the cost of healthcare services, and the efficiency that those healthcare services are delivered to generate impact on outcomes. Whether that's chronic disease management or population health management or care coordination or whatever. We have to have cross-continuum, cross-organizational information to be able to see the real picture and coordinate care across the continuum to drive real outcomes. And that requires clinical information from the providers, from the hospitals and the clinics and the practices, as well as claims information from the payers. We have to have both pieces in order to understand the true value of healthcare. And so that's what Health Information Exchange is all about, and I would submit for your consideration that it's actually a solution for the transparency discussion. So right now, Billings Clinic and St. Vincent Healthcare have about a year's worth of their data in the Health Information Exchange pilot project that we're running in Billings. Riverstone Health has about 4 years worth of data in the Health Information Exchange. Blue Cross Blue Shield of Montana is establishing a claims data feed into the Health Information Exchange right now. The claims data feed is on the heels of the provider data feeds because first and foremost, in our pilot project in Billings, we are concentrating on the clinical need for shared information. What is the clinical, how is this going to help a doctor and a care team take care of a patient better? That's first and foremost. Second is we focus on the quality of care and how does this shared information promote quality, then the business and finance case, and then the privacy and security issues, and then what kind of technology do we need to produce those kinds of outcomes. And Blue Cross Blue Shield, so that's kind of an introduction to my story about the Health Information Exchange pilot project. We announced that in October of 2015 at the Montana Medical Association annual meeting, just in a room over there. And it took several months for us to get Billings Clinic, Blue Cross Blue Shield of Montana, St. Vincent Healthcare, and Riverstone Health all to say, guess what? We are committed to working together to share information to do some pretty specific things in the Billings community. They all agreed and bought in, and we then launched this pilot project. We've got the CEOs of all of those organizations serving as the governance team for our pilot. And governance is key for any of this kind of work to occur. The governance is the magic that makes this happen. So, we've got two strong hospital competitors in the same community sharing their information. They've got to have a relationship with one another. They've got to have a level of trust with one another to share their information, and they've got to work together to figure out how that information is going to be used, by who, and for what reasons. That's what we created that in our pilot project. We also established some subject matter expert work groups, first starting with clinical and quality improvement, then business, finance, privacy, security, and technology. And we have marched that pilot project along to do three things, to accomplish three objectives and be a demonstration of success that Health Information Exchange actually can work in Montana. And the three things that we have been working to accomplish is create a community-wide view of information available to a provider at the point of care so that they can see that, the ER doc, Dr. Galley, when he sees this patient come in, he'll know that they were in the ER down the road a couple of days ago and got a narcotic prescription. There's lots of uses for, lots of reasons to have a complete picture of at the point of care. You want to have your doctors to have the best information when they're making decisions. The second thing was to identify superutilizing patients in the Billings community. Folks who are just in the ER a lot, and these are oftentimes our most at-risk folks in our communities. Certainly highest cost. So identify those superutilizers, characterize them, and track them across the continuum of care. And the third thing was to create an automated reporting platform so that we could start to illuminate quality of healthcare services using this shared information. And the finish line is in sight. We have this demonstration of success is a success. And similarly, in tandem with this pilot project, we have been orchestrating a statewide conversation around health information exchange as a solution for transparency. And we did that. So you recall that Jessica Rhodes helped assemble the state innovation model, which called out health information exchange as a priority for transformation. And then Tara Veazey and Jessica Rhodes also coordinated the Governor's Council on Healthcare Innovation that named health information exchange as a top priority. And what happened was the Montana Medical Association had physicians that were so engaged in this and involved with the leadership of the effort that the Governor's Council, in essence, tasked the MMA with continuing to convene stakeholders across the state to continue planning and building a statewide health information exchange. In December of 2016, we had another meeting right here in this building, and it was a statewide HIE conversation. We had lots of stakeholders and state leaders participating. We broke out into work groups and, again, governance, clinical, quality improvement, business, finance, technology, privacy, security, and technology. And since then, the MMA has orchestrated a number of meetings with these groups and a governing team, and we have named a new state health information exchange, the Big Sky Care Connect. And we are working on getting articles of incorporation together for a neutral, not-for-profit 501c3 health information exchange organization. And we are working on a number of items for funding, and it's kind of an important piece where the state ties back in. We also visited the governor in August of this year, and we asked the governor, can we come back at the end of the year and show you the success that our health information exchange pilot is creating, and ask you to endorse this effort as a statewide HIE, and to assign somebody from the state to be on the board, and to get behind an application process for Medicaid 90-10 match funds. All of those efforts have come to a point where we are ready to demonstrate that this effort has been successful. We are putting all of the pieces in place to build a business plan, to have a strong case to go forward with the governor and Medicaid on 90-10 match funding. Our goal is to raise $2 million of private investment to work with Medicaid and try to bring $20 million into the state to help build a state health information exchange. And that's a significant endeavor, especially in a year where we are facing such deficits. I believe that we can really leverage these funds to make a difference. This kind of infrastructure is what all participants in the continuum of healthcare need to guide their transformation efforts. And in Montana, we have a unique opportunity because, we have such great relationships with one another. We have willingness to work on these things, and we've got a tremendous amount of support in this effort moving forward right now. We've always said from the very beginning, that day we announced the pilot project, that this is a public-private philanthropic partnership. And that's what we intend to drive home with a private investment to seek after those 90-10 match funds. And so, ladies and gentlemen, I think that this is our best option for creating the kind of transparency that can actually make a difference in transforming our system to achieve that ultimate endpoint of a healthier Montana. This entity will contribute to the economy. It will enable the governing team around an HIE to shape how transparency rolls out with a focus on clinical care, on quality, and cost, and then, of course, the other pieces. So, are you in? Seriously, I want to see them. Huh? Yes. I do appreciate the involvement that everybody has, the level of effort that everybody has put into this has been exceptional. I want to thank Blue Cross Blue Shield of Montana, Mike Frank, Dr. Monica Berner, and of course our project leader Shannon Hall, who we call the Rock, because she's just such a workhorse. But really, Monica, thank you for making this opportunity real, because it was you who brought this forward from the very beginning. And so thank you for that. And thank you to Billings Clinic and all of the work that you have done. I would thank St. Vincent and Riverstone the same, and our technology vendor as well, Verinovum, that's just been a champion for us. The solution is right here. It's all teed up, ready to go. And so we need everybody here to make it work. So I challenge you, step up to the plate, throw your hat over the fence, and let's go.
All right, thank you, Dr. Griffin. We'll have a moment for some questions afterwards, but let's move on with Sarah, and we'd sure like to hear your thoughts in this area. Thanks.
Wow, that was like a cheerleading. I don't know if I should stand up with my pom-poms or my old twirling baton. I was always too tall for the pom-poms. I was never a cheerleader, I was a twirler, for those of you who remember those days. But thank you, Dr. Griffin, for that. I feel energized about it, don't you, Sheila? Yes, absolutely. So good afternoon, everyone. Thank you for having me. Mountain Pacific Quality Health, I think most of you know, is a quality improvement organization. What you might not know is we do business in Montana, Wyoming, Hawaii, Alaska, Guam, American Samoa, and Saipan. So we have offices corporately in Helena, Casper, Anchorage, Honolulu, and a year ago we opened one in Guam. And I'm really excited that 4, I believe, of our board members are in this room. So Dr. Bryce Ward is a board member, Chris Juliar, a board member, John Griffin, and I think there was one more that I'm forgetting. But what's that? Yes, Jean, of course. I'm sitting here staring at you. Terrible. It's because you're up here so much and it was just like you're part of our family. So, of course. So thank you. And Dick Brown is also a board member of Mountain Pacific, though I don't think Dick is here. I think Bob was earlier. So, again, Mountain Pacific does a lot of innovative work, what we think is innovative, but you all are doing innovative things as well. So we do everything from nursing home quality improvement to work in hospitals reducing infections, to helping physicians make sense of all the measures they have to collect We heard our speaker speaking about what we describe as initiative fatigue. We believe we're the sense makers, so a lot of our staff are out helping physicians collect measures but make sense of those measures. So lots of innovation. The one I want to talk about right now, I have a few slides to share. So Connie, do you want to drive the bus for me? That would be great. Dr. Griffin just spoke about superutilizers. So are all of you familiar with hotspotting or superutilizers? I think I'm seeing some nods. So basically that's just folks like the Billings Clinic, for example. Billings area, Missoula area, and Helena area are all part of a special project we were awarded by the Centers for Medicare and Medicaid Services. And what we're basically doing is identifying those patients that are bopping in and out of the hospital, the emergency room department, and then figuring out interventions that the community can coalesce around to do something about those patients so we can keep them at home. Heads on beds is another way of describing that. Next slide. So we are calling this the Rural Frontier Superutilizer Project. A lot of urban areas have done this work for a number of years, but it's never really been done in a more rural frontier area. And so it began September 18th, 2015. And a number of barriers, two of them, lengthy process in getting the communities to be organized in a neutral way and to get community health workers hired, and then a lengthy process about deciding on what interventions those communities were going to focus on. So one of the keys is resource teams. So we have a number of resource teams deployed. I'm going to talk more about the Kalispell area. They're a little further along than Missoula and Billings and Helena. So resourcing for superutilizers always puts the patient in the center. So this depicts the ideal model, and obviously you've got community health workers to include social workers, nurses, pharmacists, a whole host of adjunct healthcare folks that are working to identify those patients in the community and then either going out to their homes and helping them or helping them where they are in the nursing homes or wherever that might be. So it's really a holistic approach. Next slide. So this is a depiction of the Montana communities that we're talking about. So if you look at Kalispell as an example, we've got one RN part-time and a community health worker. In Helena, we've got an RN, a community health worker, and a social worker. And then in Billings, we have an RN, and we had 2 U.S. veterans, military veterans, working with a cohort of patients that's rather unique. I think that it bears some comment. These individual veterans were disabled. Both of them were medics. They had other jobs, but they were missing the medical field. And so they applied for a position that we funded through the Billings community, and they were hired, and they're just outstanding. And so we are recommending to CMS that they start looking at the veteran population as a pool of community resource teams. So, next slide, and how it works. Again, these community resource teams, we are providing them with deployed iPads. So communication between the patient and the community health workers can be done via FaceTime. They can text message. They can do a whole host of things to reach out to receive assistance. So in the Kalispell area specifically, the RN goes out to different resource areas in that community and finds help, whether it be meals, housing, or what have you. And the iPads have been very effective in getting that communication. And I don't know, Billings, are you all using iPads? Do you know? I don't think so. Okay. All right, now let's go to results. So return on investment, everybody wants to know about that for sure. So right now, look at the bottom line, if you can see it. in 10 short months, it's $1.685 million in direct savings in this project. So Billings, Helena, Kalispell, 10 months, pretty significant. And we're seeing even more now as momentum is building. I think we've got data pretty soon. By the end of December, we'll have data likely through August. And I think that number is going to go up dramatically. So it can work for sure. We're also looking at some of the Medicaid data that we hold. We have our state partner right here next to me. We hold a number of Medicaid contracts. I think we've got 8 or 9. Thank you, Sheila. And we do everything from drug utilization, prior authorization, and a whole host of other things. But one of the things we've identified are patients that are bopping in and out of the emergency departments, hospitals, transportation, and drugs. So we're looking at a way to do that to maybe help the department. So what's next? Going beyond Medicare patients, we received a Robert Wood Johnson Foundation. The folks at Robert Wood found out the work we were doing and asked us if we would submit a grant to work on super utilizers for non-Medicare patients. So we're doing that for them. The project ended, but we've been given a no-cost extension to carry us through next spring. And right now it looks like that project will be sustainable. So we're very excited about that, as is the Robert Wood Johnson Foundation for sure. And then the next slide is a resource for you. I would imagine these slides will be shared. PBS NewsHour aired a program on the Kalispell experience in June. And if you haven't seen it, we've tried to broadcast it widely. If you haven't seen it, I would encourage you to. They did a beautiful job going to a couple of patients' home and really showing how community resource teams and the work that the folks are doing in Kalispell is making a huge difference. So that is available for you. And the final thing I wanted to comment on is innovation around diabetes. Jean mentioned work we do in diabetes. We work on a program called DEEP. So Diabetes Empowerment Education Program. And right now we have 26 county extension agents trained in the program, and they're out making a huge difference educating folks with diabetes how to take better care of themselves and control that particular condition. So that's another exciting thing we're doing. Stay tuned. We've got some results that are pretty cool. So thank you very much.
Thanks so much, Sarah. That's some exciting stuff that's going on, and I know that those have been huge pieces, is identifying those super users. So Sheila, we'd love to hear your thoughts.
Thank you. Thanks for having me here today. It's oftentimes I don't know that people put a stuffy bureaucrat alongside of innovation, but I will share some of the things that we've been doing. I started in the department in January. It's a job I've always wanted, but I didn't realize it was going to be quite so difficult over the last couple of months. I feel like we've done a lot of wheel spinning, and I'm hoping now that we can take a look at what we have and move forward. I'm glad when you mentioned the data system that you talked about 90-10 money. 90-10 money means 90% federal money, 10% non-general fund. I'm glad you mentioned philanthropic, because if you read the paper, there's not a lot of general fund sitting around in Montana. So I think if we're going to go that route, we're going to need to do some work collectively. Kind of the old public health adage, the feds have the money, state has the power, but the locals get the problems. And you all know that. So these cuts are going to be impactful to all of you. I hope that we can sort of weather the storm together and take care of the populations that mean a lot to me, and I know they mean a lot to all of you. I would be remiss if I didn't talk about innovation and talk about Medicaid expansion. Medicaid expansion and the positive impact, your chamber members, many of you, we need to talk about the positive impact that that has had on the economy. Medicaid is the, Medicaid and Medicaid expansion are really the most powerful vehicle that we have to fund coverage of prevention and treatment for those at risk and those battling substance abuse and addiction. There's only a handful of states that have rates that exceed Montana for substance abuse and misuse. More than 13% of the deaths in Montana are individuals 20 to 64 and due to excessive drinking. One of the highest in the nation. 65% of the children removed from homes are due to substance abuse and misuse. That is, it continues to grow. We have almost 4,000 kids in care in Montana. That's something that I wake up in the middle of the night thinking about. We need Medicaid expansion. It really is, it's allowed us to provide desperately needed mental health and addiction services for the first time. We had a limited block grant, and that's how we funded treatment. But Medicaid expansion has allowed us to really open it up and provide services to people who need that treatment. The Montana HealthCare Foundation, thanks to Aaron, they did a third-party evaluation of Medicaid expansion. And that's a third party looking at the data, and it really is, it's quite amazing and quite impactful. So I don't want to steal your thunder if you're going to use that in your presentation. The report provides compelling data on the benefits of Medicaid expansion. We talked a lot about partnerships. Since Medicaid expansion was enacted in 2016, there has been $574 million in healthcare services provided in Montana. $574 million. It's saved the state $30 million through refinancing. So we're also able to provide services for members with children between ages 24 and 50% of the federal poverty level. Members with severe disabling conditions, medically needy individuals, women in breast and cervical cancer programs. You know, you hear a lot, kids talk about joys and concerns. My joy is Medicaid expansion. My concern is that it sunsets in 2019. So I'd like to have, when you talk about raising your hands, I'm not going to do that, but I hope that we can count on your support to make sure that that program continues. I'm not going to talk a lot about what work we've done with naloxone. Thanks to Dr. Holzman and to Dr. Galley, we now provide naloxone in Montana to our emergency responders. Dr. Galley did a great job of sort of dumbing down what we do with naloxone for a non-practitioner. We had a great press conference, and I didn't really see, I knew it was valuable, but till Sheriff Dutton talked about the impact that that's going to have on those first responders. I'm really excited that we're going to be meeting with the Montana Medical Association, along with Dr. Holzman, our Medicaid director, and various division administrators, so that we're going to come together and see how we can collectively impact the health in Montana. And I'm sure that Jean will be reaching out to all of you, and I will as well. I guess if we talk about innovation, the most exciting thing, and I wish I could take credit for it, but I can't, it started well before my time. Mary Dalton was the former Medicaid director. It's the Tribal Health Improvement Program. It's the first in the country, and it provides prevention services on reservations. I think this is interesting. If you really think of tribal health care, it's a block grant. So if you want to talk about block grants, that's a block grant. So they really are, they focus, because of limited money, on life and limb. But because of Medicaid expansion, they're able to bill for services. But now with the Tribal Health Improvement Program, we're focusing on the prevention side. So it is $64 million, 100% federal money that will go directly to tribal governments. So it's a historic partnership with the federal government, with state government, and with tribal government, that we come together and look at what do they need to deal with prevention on reservations. It can also be very culturally relevant. They're the deciders of what to do to deal with prevention. We actually delivered, I talked about 64 million, upwards of 64 million a year. We delivered checks to talk about the impact on the reservation, and to see the tribal leadership actually cry, because they will finally be able to deal with the prevention side for their members. So to me, that's what really makes my job exciting, is some of the impact that we can provide for the really disadvantaged population. So I'm very excited about that. And I'm looking forward to working with all of you over my tenure and really helping to improve healthcare in Montana.
Great, thank you so much, Sheila. I mean, we know that you have had a lot of challenges for Department of Public Health and Human Services. You can't avoid that when you pick up the paper, and funding is going to continue to be such a huge issue. So to hear what you guys are doing is really, truly remarkable, to hear some of the progress that you're making. So one of the questions I thought maybe, this is a key panel. When I was asked to moderate that, I thought about that, because any of us working in the healthcare field, at the end of the day, each of these folks has talked about costs. That was part of what they were asked to talk about, and the innovations that they are spearheading in order to address costs. So one thing I'd like to ask each panelist to think about is, if you had the power to make one action come true, or initiate one program or one initiative that you really felt would impact cost, and you knew that just your desire to do that would make it come to pass, what would that be? And I want you to also think about that out here too, because we're going to take questions from the audience next. And so what I'm trying to drive at really is, how do we really address, at the bottom line, the cost? What do we think is going to be the best silver bullet for achieving that?
I'll go.
Okay.
We need to deal with the cost of pharmacy. I don't know that I have a silver bullet. We did a lot of good work when I used to be with the healthcare and benefits folks, when I was at the Department of Administration. But we are now going to come together with them and look at collectively the cost that DPHHS spends on medication, what the state of Montana spends, and to see if there's some work collectively as an enterprise that we can do together.
Yeah, it's an interesting question, because we don't deal directly with cost, though we should. And so I would say I have a board member in Wyoming who is a physician in a primary care situation, and he has developed something that is a little controversial called 307 Health. And it is a practice model in which his patients pay per member per month. And his patients also have to have insurance, because he doesn't cover hospitalizations or emergency room visits. He takes absolutely no insurance, Blue Cross Blue Shield, Medicare, Medicaid, nothing. And his charges are around $35 to $40 per month. And when he presented to our board, and then I got him in front of some CMS officials, Even the CMS officials were saying, wow, I want that. And it's just a fascinating model, so I would probably be czar of the world in King, and I would implement more of that in our rural areas.
Wonderful, great.
My answer should be pretty obvious.
Really?
Yes, so I'm thinking about a neutral, not-for-profit entity that houses health information from hospitals and clinics and first responders and the tribes and the prisons and the university systems and the optometrists and the dentists and Blue Cross Blue Shield of Montana and Pacific Source and Allegiance and Medicaid and Medicare, all submitting data into one place with a powerhouse governing team of decision makers and leaders from across the state who are deciding how this health information is going to be used to guide transformative efforts across the continuum of care and in every component of healthcare.
Fantastic. Those are some great answers. And I will apologize to the panelists. I sprung that on them. But I did that on purpose in some ways, just because you thought about the process, but you've also thought about it too. So I'd like to open up to the audience for questions for our panelists and to talk about this topic. I mean, what's on your mind as far as innovation, and how do we approach the cost problem that we have in healthcare and medicine in the United States? And I see a hand up here, over here. So Heidi.
Thank you. I think we are remiss not to mention something that I think touches both innovation and hopefully cost reduction in this room, is a Comprehensive Primary Care Plus, which I think is a big win for the state of Montana. For those of you who may not be familiar with it, it was part of the MACRA legislation, and only 6 states got to participate. For us to participate in Montana, it is truly a public-private partnership. It's the major insurers, Medicaid, and the providers, we all have to participate to do this. As so I'm wearing now my family medicine provider hat with my health policy lens. I've been practicing here for 23 years, and we've done some exciting work building on patient-centered medical homes and the teamwork that we've all talked about. But the CPC Plus money that's come into the state and into our practices, I think has taken this to a whole new level in my personal experience and my ability to care for my patients. At Billings Clinic, we've been able to add more care managers. We've been able to do integrated behavioral health and have a licensed social worker as part of our practice. It's given us the ability to hire pharmacists. All the things that we know help improve care. I think already in the 9 months we've been doing it, I've seen improved patient outcomes, more efficiencies, and I'm really hoping we can get some good cost reduction data too, because I think that's really important. But I wanted to give a shout out because it was really an important partnership that a lot of us participated in, so thank you. It's exciting innovation.
It's a great point. It's a great point, Heidi. Thank you for bringing that up. Blue Cross Blue Shield, of course, has had a PCMH model in the market since 2009, and I've seen that, participated pretty actively in this for over the past couple of years. But you are right. The change that is happening throughout the state and in many organizations all over the state, we are seeing real movement with respect to the enhancement of the delivery model side of it that I agree will result in cost savings. And by the way, the HIE is an automated reporting platform that the CPC Plus participants can all use and all be contributing data to, so that everybody's results, the outcomes that we've got to be accountable for, will, instead of every individual healthcare organization and hospital having their own IT staff and whole team of people to run data and measures on their limited set of data, and HIE brings all of the data there, so the measures go up, and then you just kind of make it push button and automated and have it just be simple and put it right in your care team's laps so it's actionable when you're taking care of folks. Yep.
If I might add, Dr. Duncan, thank you for your letter on Part C. And I do believe we're okay with Part C, and you can keep that in your menu of services, so.
Well, and I have to add one thing to Dr. Duncan as well. I'm glad you brought up CPC Plus, because one of the things I talked about was we have staff out in the field who are sense makers, and so we actually have a subcontract to help folks implement and do CPC Plus. So it's a win-win for everybody. Yeah.
I just have a quick question. I'm Cindy Sturgar from the Primary Care Association, and we serve about 106,000 Montanans through community health centers and work with many of you as partners and work with all of you up there as partners in everything that's happening. So I also recognize many of you because most of us have been here at least one day every week this month at some conference here. So I'm curious from the standpoint of what we know from the evidence is that the things that really make our health care, really make us healthy, don't usually happen in the hospital, nor in the clinic, nor in the HIE, but are about things that now we term social determinants. And if you were an old-time farmer, you would know it was just the ordinary things that make up your life. And if you don't have those things, you're probably not going to be healthy. So I'm wondering, from all of the work that everyone's doing, because Sheila, there are some states where Medicaid is paying for housing via managed care companies, but they do. And I'm just wondering what your thoughts are as we go into this arena of really trying to take care of our communities that really happen. It's not just about care coordination through CPC Plus, so that's a step in the right direction, but really going out into food insecurities and housing and the zip codes, all those kinds of things that we know are 94% of why we are going to be healthy or not.
Cindy Sturgar. I know that Medicaid in some areas can pay for housing, and if you look at almost 4,000 kids in care, that's one of the biggest hurdles is housing. Bringing people home from the state hospital, it's housing. So we are definitely working on that. I've met with the Commerce Director, Pam Haxby, and they have non-general fund money. So I'm hoping that we can do some of that collectively and could sure use your help.
So, Cindy, I couldn't agree with you more. The Mountain Pacific's program, she talked about a community resource coordination program, and I should probably let you talk about it more. But this is an area that's really near and dear to my heart as well.
As a board member, he's one of my bosses.
Yes.
Go right ahead.
He's switching hats.
Yeah, go right ahead.
That program is designed to hone in on the people who are most at risk in the communities that are participating. So these are the folks who are, it's the homeless person that's got mental health challenges and lots of psychosocial issues that is showing up in the ER every week or every other week and driving costs. And this program is focused on identifying the biopsychosocial and economic, those kind of needs. And then, it's called community resource coordination because the idea is by focusing on the simple stuff. Do they have a ride? Do they have their meds? Are they taking their meds right? Do they have the right kind of food in their house? Do they have social support? Those simple things. These community health workers they don't necessarily have to be a licensed professional, but they do need to have some training to go and do this kind of work. And there is mounting evidence in this program that it makes a huge difference. Just these few people. Gosh, I think that Laura said that it was, I don't remember exactly what the numbers were, but they were very impressive. Just with a few patients who were involved, I think it was 1.6 million for 27 patients that were enrolled over the last 6 months. Is that right?
Almost, yeah.
So, anyhow,
It's close enough.
it's there is an opportunity, and I think you're absolutely right. The Montana Hospital Association has been convening a series of meetings as well to establish a training curriculum for community health workers, and is talking about housing that kind of education in the MHA. And this is work that's been led by Chris Juliar in the Area Health Education Center for a long time, actually assembling the curriculum. And so it's been a long time coming for this program, but the idea is that maybe in 2019 we can have some sort of certification or licensure status for these community health workers to actually be a legitimate care team member and part of the workforce, which I think is an important and really cool thing.
I love the veterans aspect.
Jim?
Yeah, question for Sarah. So on this Hot Spotters program that you've got going, will that be something like EBMS, their clients and employer group could access that? I mean, is it going to be something that's going to be packaged and that a large employer could purchase the component to add to their health plan?
Thank you so much, Jim. I'm glad you're retired now. Maybe you can come to work with us in our business development shop, because that is exactly where you could go with this for sure. Yeah, that and a host of other things. But yeah, you're absolutely right.
Yeah, and it's really important having a cross-continuum view of information so you can identify those individuals and understand where are their opportunities and be able to track their progress when you get them in a program.
How the hell would you do that?
I know.
I think we have one more question.
Oh,
Thank you.
I just wanted to get in on this one wish, if we could, of how to change the system. And it's going to go back to the same thing that we talked about at the very beginning, but we've been discussing about healthcare costs since the 70s, and we've continued to go in the wrong direction since then. And I would, again, if you look at some of the other countries, not all completely the same, one of the biggest differences the integration, again, of public health services and human services. And again, I would say, I don't think we're going to take money from one place and put it in the other. I know that doesn't happen. But I would love to see that the clinical healthcare system and the hospital system reach out and integrate more of our public health and our human services so we work in a more collaborative way. And I do think we would make a big difference in that way for helping people and maybe even helping cost.
Great, thank you. I appreciate that. Well, I think right now, thank you very much for all of the participation from the folks here and for the panelists as well. Some really very thoughtful, a lot of hard work has gone into the initiatives. And so I think we'll take about a 10-minute break right now, and then we'll come back and catch up. Thank you, panelists.